All right, so we're gonna go ahead and get started. So we're gonna get through chapters 18 and 19 today, and maybe a little bit of chapter 15, because the less stuff we have to do today, the more stuff we get through today, less you guys have to do on Monday right before your exam. Okay. After. Okay. Exam scores won't be out until Monday afternoon because we do have makeups. So I know I've been getting asked that a lot, but exam scores can't be out until everyone's finished. So, all right, so the respiratory system and cardiovascular system are going to work very closely together to provide the body with oxygen and remove carbon dioxide. Okay, so you're bringing in oxygen, you're getting rid of carbon dioxide. However, your respiratory system is going to do a couple of other things as well. All right. What is this? Sorry. For some reason, Engagely has like 2 windows open. There we go. Okay. So, it's going to influence production or sound production in speech. It's going to give you the sense of smell, and it's going to help maintain homeostasis through regulation of acid-base balance. Okay, but like I said, there's a whole bunch of different things that do acid-base balance. So the main point of this, bring oxygen in and remove carbon dioxide. Chapter 18, 19, and 20, or sorry, not 21. Chapters 18, 19, and 15 are all in that one packet that I handed out. Juanita.
Hi, Professor. Are you showing the slides? Because I can't see them.
Yeah, it's up here. You might just have to like click class gallery and then back to file share.
Okay.
Otherwise, right. Just out and log back in, and that usually takes care of it.
Okay, then. All right. Thank you.
Yep. So, you're still unmuted.
Oh, sorry.
You're good. So your respiratory system is going to get divided into 2 tracts. You have your upper respiratory tract and your lower respiratory tract. Okay. Your upper respiratory tract is going to be everything outside of your thoracic cavity. Lower respiratory tract is going to be the stuff inside of your thoracic cavity. We're going to talk about these more in depth. So, starting with your upper respiratory tract, okay? Upper respiratory tract, you have 3 structures. You have your nasal cavity, your pharynx, and your larynx. Okay. These are going to be responsible for warming and humidifying air, the sense of smell, taste, and for swallowing food. Okay. So the whole point of this, you're bringing things in. It's also going to contribute to like filtering dust and trapping things in your mucus. And we'll talk about how that like kind of works in the lower respiratory tract in a minute. Now, air is going to enter and leave the respiratory system through your nose. Okay. You can also breathe in through your mouth, but enters and leaves your respiratory system through your nose. Now, just inside your nose, you have these little hairs called cilia that are going to be responsible for filtering dust and large foreign particles. Okay. Now, we've talked about this structure before, the hard palate. The hard palate is going to form the roof of the mouth, and it is going to separate the mouth from the nasal cavity by a structure called the palate. The palate is going to separate the mouth from the nasal cavity. Sorry, I've had been tongue-tied like all day. I don't know what's going on. So my first 2 classes were like this too. I apologize. Now running in between the middle of Jasmine.
What was 1, 2, and 3 for the upper respiratory tract?
Your nose, your pharynx, and your larynx. And I did just send the slides out to you guys, so you should have those now.
You said the nasal, the larynx, and pharynx.
The nose, the or nasal cavity, pharynx, and the
Oh,
larynx.
all right. Thank you. I get it.
So now running in the middle of your nasal cavity, you have a bony structure called your septum. Okay. And your septum is going to separate the nasal cavity into two halves. So you have your left and your right. Now, lining this cavity, you have a bunch of goblet cells, and just like in the stomach, goblet cells are going to be secreting mucus. Okay. Now, coming from the lateral walls of each of these nasal cavity, you have something called nasal concha. Okay. And nasal concha, normally I show in that like 3D anatomy app that I have, but Brian just updated my computer. I haven't had a chance. I haven't had a chance to download the whatchamacallit, the, why isn't this letting me do it? The anatomy app again. So nasal concha, if you look at them from the front, okay, they're literally like these like curved structures that go through like this, okay? Now, what these do is they're gonna like warm and humidify air as it passes through. So your air isn't just coming in through a hole, okay? You have structures set up there that it's gonna pass over, and that is gonna warm and moisten the air as it flows past, okay? And at the same time, you have that mucus, and dust is gonna be getting stuck in that mucus and then swallowed, so that you can like bring it into your digestive system, so it can be excreted out, okay? Now, coming through the roof of the nose, you also have branches of your olfactory nerves, okay? So branches of your olfactory nerves are going to come up through the nasal cavity and go through the brain, or go to the brain, not through the brain. Now, just behind the nasal and oral cavities, you have a muscular tube called your pharynx, okay? And if you remember, right, we talked about the pharynx back in chapter 21, right? We talked about the digestive system. The pharynx is the throat, okay? Now, your pharynx has three divisions. You have your nasopharynx, your oropharynx, and your laryngopharynx, okay? Now, whereas food is only going to pass through your nasal, or sorry, not your naso. Food is only going to be passing through your oro and your laryngeo. Air is going to pass through all three, okay? Now, nasopharynx is going to be just behind the nose. It has openings for your eustachian tubes, okay? So this is where your eustachian tubes come in. The oropharynx is going to be right behind the tongue. It's going to be where you find your tonsils. And then the laryngopharynx is going to be just below and neck, but behind the larynx, okay? And it will connect to the esophagus. Now your larynx, on the other hand, so the larynx is going to sit right in front of this. So this is your larynx right here, okay? Your larynx is a chamber that's going to be formed by cartilage and muscle, and it's where your vocal cords are located, so it's called the voice box. But it is also going to be responsible for preventing food and liquids from entering the trachea, which is like the next part of the respiratory tract, and it's going to be an air passageway through the pharynx and the trachea. So looking at it from the front, we have like two big landmarks here. So looking at thyroid cartilage first, okay? Thyroid cartilage is commonly known as your Adam's apple. Now, women also have Adam's apples, but so women also have Adam's apples. They just aren't as big, okay? So, sorry, my camera got messed with. So your thyroid cartilage is going to be like right here. All right. Now this is like lower than your hyoid bone. Your hyoid bone is going to be like buried up in here. Okay. So again, hyoid bone is going to be like what's broken if somebody's getting strangled, because there's like not really a reason why this bone would be broken otherwise, right? So thyroid cartilage is going to be right here. Okay. Adam's apple just tends to be bigger in men, which is why men have Adam's apples more often than women do. Next, you have your epiglottis. The epiglottis is going to block food from entering that respiratory tract. Okay. You can see it better on the side view, so I'm going to hold on for a second. I'm showing that to you. Okay. So looking at it from a side view, your epiglottis is going to be this flap right here. Okay. So what happens as food comes in, I'm going to draw a food bolus in green. Okay. We swallow our food bolus, right? And as it is passing down, your epiglottis, this like flap right here, is going to snap shut. And it is going to keep that food bolus from entering the respiratory tract as it moves down. And that'll push it down into the esophagus. Okay. So your epiglottis is going to block the food from entering the respiratory tract. Now, vocal cords, I just like to talk about how they work a little bit. So vocal cords work very similarly to how guitars work, right? So the way that vocal cords work, you have certain, like when you tune a guitar, right? You have those tuning knobs. You can tighten the strings or loosen the strings to change the pitch, okay? And then when you bang on the chord or like strum the chord, it causes that vibration. So it causes those like chords to move, right? Same thing with vocal cords. You have certain muscles that are going to contract to tighten or loosen and adjust that pitch. And as air passes through, it causes those vocal cords to vibrate, which is going to produce that sound. Okay. So if it's looser, it's a lower vibrating sound. If it's higher, it's a higher pitch sound. Micaiah. Makia? I thought I said it right the first time. No worries. Okay, your hand's up. So if you have a question, just like type in chat. Or unmute. I don't know if your hand's up by accident. So.
What does the trachea split into? Did you go over that part?
Not yet.
Okay.
You said the vocal cords produce sound, but the pharynx, what does that do again?
The pharynx is the throat. So that's going to be where like just kind of like the digestive tract and the respiratory tract finish meeting up.
No, I was talking about the last slide before this question.
The epiglottis? You talking about the epiglottis?
Vocal cords. You said
that was just for like background information.
Oh, okay.
You don't, yeah, it just produces sound. It's just to explain how it produces sound.
Okay.
You don't need to know the ins and outs. You're good. All right. So function of the nasopharynx provides openings for the eustachian tubes. Okay. Even if you don't remember specifically that the nasopharynx has the opening for the eustachian tubes, these other three are all functions of the nose. So process of elimination, eustachian tubes. Your book goes into way more detail with the things than what we're doing for the last 3 chapters, just since we're bringing it up. So I'll like some of the stuff I'll like go into a little more detail about than what's in your packet just to like explain the concept to you. But like, again, if it's not in your packet, we won't test on it. So. Now talking about your lower respiratory tract. Okay, your lower respiratory tract is going to consist of things inside of your thoracic cage, so inside of your rib cage. You're going to have your trachea, your bronchi, and your lungs. Okay. The whole point of it is to distribute air to the interior of the lungs. Okay. So going down, your trachea is going to split into your primary bronchi. Now, primary means first, secondary means second, tertiary means third, right? So your primary bronchi is going to be the biggest, secondary, second biggest, tertiary, third biggest, okay? The tertiary bronchi are then going to split into bronchioles, which split into alveolar ducts, which will split into alveoli, okay? Or which will lead to the alveoli, which is going to be where gas exchange occurs, which we will talk about in a little bit. Now, between the two bronchi, okay, they actually have a slight difference between them. The right bronchus is going to be slightly wider and more vertical than the left, which makes it more likely for objects to get stuck in there. Okay. So, which of the bronchi is a foreign object more likely to be lodged in? The right, because it is wider and more vertical than the left. I'll give you a second to finish writing that.
Professor, can you, that was, you're answering the question, right? Under, can you repeat it again or can you highlight it?
Yeah, it's, where's the little annotate thing? This thing right here. So it's the more likely location because it is slightly wider and more vertical than the left is. Okay. If you want to know more detail about the structure, it's here for you. If not, don't worry about it. So next, talking about cilia inside of the respiratory system, okay? Cilia are going to be those little projections on the cells that are like hair-like, okay? So cilia in your nose are actual hairs. Cilia on your cells are hair-like projections. We talked about cilia back in chapter 3, right? Where they're going to do that crowd surfing motion. So for which structures line the bronchial tree and help mucus move towards the pharynx, it is going to be your cilia. Now, the problem with cigarette smoke is going to paralyze these cilia. And so what happens is that mucus is going to accumulate in that lower bronchial tree, and your body is going to try harder to cough it out. So that is going to result in that typical smoker's cough, as the lungs are going to attempt to clear that mucus, okay? So why does cigarette smoke cause smoker's cough? Because cigarette smoke is going to paralyze that cilia. Okay. So cilia is going to paralyze, cigarette smoke will paralyze the cilia. Ah. Now, is there a multiple choice question next? Yep. For this next section in your packet, I meant to like make it its own section. I'll show you what I mean. So I meant to put like gas in the header, and then I forgot to like put a new header there. So if you want to add it so that your notes are more organized, that would be good. if you don't end up remembering to add it, or you're like ignoring me right now, it's not going to change your notes too much. It just makes it easier when you go back through. Okay. Gas exchange, that's our next topic. Okay. So gas exchange is going to occur in the alveoli. All right. Now these alveoli are like 1 cell thick. Okay. So the whole point of your trachea to your bronchi to your secondary bronchi to your bronchioles, so on and so forth, right, is to bring air down into these alveoli. Okay. Now you don't want to overwhelm the alveoli with air, which is why you have these like really narrow things at the bottom there. And the structure of the alveoli, okay, you have a whole bunch of capillaries and veins surrounding it so that that gas exchange can occur, okay? And they have very, very, very thin cell walls. They are just 1 cell thick and they are 1 flat cell, all right? So during inspiration, air flows into the alveoli, inflating them like tiny balloons. So in order for this to happen, okay, alveoli need to expand with air and recoil, but they also don't want to collapse. So we're going to talk a little bit about factors that influence airflow later on. And we'll talk about why having lung compliance and having alveolar surface tension is important then. Now, as gas exchange is occurring, okay, your red blood cells, right? The whole point of respiration, the whole point of breathing is to bring oxygen into your body and get rid of carbon dioxide, because we are using oxygen in order to do all of the metabolic processes that our body needs to do. So as our cells are doing these metabolic processes, okay, they are using up that oxygen and they are creating carbon dioxide as a byproduct. All right. So they use up the oxygen, they get rid of that carbon dioxide. So the red blood cells then are going to be picking up new oxygen and getting rid of that old carbon dioxide. Okay, so where does gas exchange occur? Alveoli. During gas exchange, what moves into the red blood cells to be carried to the rest of the body? Oxygen. What moves into the lungs to be expelled? Carbon dioxide. Okay, so oxygen's moving into the red blood cells, carbon dioxide is moving out of the red blood cells. Because then the lungs, when you breathe out, get rid of that carbon dioxide. This is just a little bit more information about the lungs. If you want to know more about lung anatomy, okay. So on your guys' diagram in the packet, I only have you labeling 3 things because it's like a black and white version of this. I have you labeling the trachea, the lungs, and then the diaphragm. You don't need to know the lobes. You don't need to know the fissures. Don't worry about that stuff, okay? Next, talking about airway suctioning, okay? The whole point of airway suctioning is to keep the airway clear so that oxygen can actually reach the alveoli where gas exchange is going to occur, okay? So airway suctioning, you want gas to actually reach, or oxygen to reach the alveoli where gas exchange occurs, okay? Now you would use airway suctioning when a patient cannot clear secretion on their own. So either due to weakness, sedation, or they have excessive mucus. So what can happen is that airway can become partially blocked, which will reduce flow to the alveoli. Okay. Next, we're going to talk a little bit about asthma, because asthma is very, very common, especially in the United States. So you guys are bound to come across it if you have not already. Asthma is going to be a chronic inflammatory condition, meaning that it is long term, right? That causes your airways to become narrow. Okay. This is called bronchoconstriction. What does broncho refer to?
Bronchitis.
So bronchitis is another condition, but what does that prefix broncho mean? What is the trachea split into?
Windpipes.
So bronchi, right? So broncho, you were just talking about the
Bronchi.
bronchi, talking about the bronchioles, all of that stuff. Okay. So bronchoconstriction is a tightening of those bronchioles, those bronchi. Okay. So what happens is they become more narrow and swollen. This is going to lead to wheezing, shortness of breath, chest tightness, and coughing. Okay. These can get triggered, or triggers are going to include things like allergens, infections, cold air, and stress. I've seen exercise-induced asthma. There's a whole bunch of things that can kick off an asthma attack. Okay. Now, inhaled medications are going to deliver drugs directly into the lungs. Okay. This is going to provide faster relief and fewer systematic side effects than the oral medications, right? Because you're putting it right where it needs to go. What the whole point of these to do is bronchodilation. Again, broncho, you're talking about your bronchioles or bronchi, dilation, expansion. Okay, so bronchodilation.
Professor, I have a question.
Mhm.
When you was talking about different things that can cause an asthma attack, is the weather changing one of them?
Yep. See, cold air. Yeah. Asthma can get triggered by like anything. I don't know. A breeze blows the wrong way and it's sending some pollen up your nose. Causes asthma or an asthma attack. And so, yeah. So one of the ways we counteract this, nebulizer treatments. Okay. So a nebulizer is able to convert liquid medication into a fine mist for inhalation. Brianna. No. Okay.
I missed the symptoms of the asthma. Can you go back?
Yeah.
That was where it says the wheezing, the shortness of breath, the chest tightness. Is that what that is? Okay.
Yeah. All of this stuff.
Let me just take a picture real quick.
I sent
Thank
out the slides too. You should have them in your email if that's easier. I just sent them out, so. Nebulizer treatments. So, nebulizer treatments is going to convert liquid medication into a fine mist for inhalation. Okay. So you're going to use a nebulizer when a patient cannot effectively use an inhaler or during acute episodes. Okay. So like, for example, kids, not always the best at following instructions. Okay. So a lot of the time nebulizers get used with kids because it's just more effective. It's a mask that just sits over their mouth and nose, and they sit there for about 5 to 10 minutes to breathe. It can also be more effective during acute episodes. So I remember like my cousin has asthma. My grandmother used to have a nebulizer, so he'd have to do these things all the time. It's only for like 5 to 10 minutes, but your roles, maintaining or monitoring patient breathing, documenting the response, cleaning the equipment, right? Because if the asthma attack is brought on by something like an allergen, right? So I don't know, they got blasted with a whole bunch of pollen, okay, caused an asthma attack, they go to put the mask on. They feel better. Okay, they're cured of that asthma attack. Next time they have an asthma attack and they go to use this nebulizer, if there's a bunch of pollen inside of the mask, right? You're just going to be re-exposing them to all that pollen that caused the asthma attack the last time. So making sure that you're cleaning this equipment really well is very important. Sorry, that was my apartment's like maintenance guy. Eloise's like ceiling is falling in, so they have to come paint it and fix it. So been trying to set up an appointment with them. Yeah, so inhaled food or objects are most likely going to be lodged in your right bronchus. Okay. So the right bronchus, because it is wider and more vertical than your left bronchus. Pharynx, the pharynx is pretty wide. So like, yeah, things can get stuck in there, but probably will fall a little further down if it's like really stuck in there. Bronchioles are really, really small. It's probably not going to travel all the way down there before it gets stuck. So next, talking about pulmonary ventilation, okay? Pulmonary ventilation is just a fancy way of saying breathing. Okay, so it's going to depend on the action of respiratory muscles as well as differences in pressure. So we'll talk more about that like a little bit, but you guys don't really need to understand the differences in pressure too much. Okay. Now, one respiratory cycle, that is just one inhalation and one exhalation. Okay. So one inspiration, one expiration. That is one respiratory cycle. Okay. Very simple. Now we watched this during when we did like chapter 8, not 8, what is it? Chapter 10. The reason why I like showing it again, it just shows you why contracting the diaphragm and moving the rib cage around, like expanding that thoracic cage, or like how. Okay. So we don't need to watch the whole thing again because it just goes through all the specific muscles. But the idea is when you contract that diaphragm, right? It's originally a dome shape. Okay. When you contract it, it's going to flatten down. You're going to bring your rib cage up, create more space, and that's basically going to suck the air in. All right. Now, the main muscle of respiration, again, is going to be your diaphragm. It is going to contract during inspiration, okay? Because it flattens and it causes the space in the rib cage to increase, which essentially sucks in the air. Okay. So, you also have a ton of.
I'm sorry, Professor Woodrow. Can you repeat that? You said that. Can you say what you said again? I'm sorry.
It flattens and causes the space in the rib cage to increase, which basically sucks in the air.
And you said this happened during inspiration or expiration?
Inspiration.
Okay.
All right. So you have a bunch of respiratory muscles, accessory respiratory muscles, okay? You're really only going to use them during times of forced or labored breathing, okay? So that's going to be when you're like taking extra deep breaths in, when you're like shoving that extra air out, and you're like contracting your abdomen, all of that stuff, okay? So during those times of forced or labored breathing, you will use your accessory muscles. Don't worry about knowing the accessory muscles. Okay, unless it's in your final exam review packet, which we're finishing up. Okay, which I don't think it is off the top of my head. Phrenic nerve paralysis. Okay, the phrenic nerve is going to control the diaphragm. The phrenic nerve is the reason why neck injuries are so dangerous. Okay, because the phrenic nerve is going to start at the third level of your cervical vertebrae. Now, a spinal cord injury above this level can cause paralysis of the diaphragm. So the phrenic nerve is the exception to like that rule of thumb that I told you guys where like the spinal nerves are coming out of the spinal cord, close to like the thing that they innervate. The phrenic nerve comes out of your neck, travels all the way down to your diaphragm. Now, the reason why it's a problem, okay, if your phrenic nerve gets damaged, okay, it is impossible for the person to breathe on their own. All right. So, yeah. Which nerve controls the diaphragm? That is your phrenic nerve. So first thing you do when you suspect a cervical injury, a neck injury, is you put a cervical collar on them, right? Because you want to stabilize that neck. You do not want any sort of damage to your phrenic nerve. Among other reasons, but like the phrenic nerve is a big one. You want to be able to breathe. like 10 more seconds. Yeah. So the main muscle responsible for pulmonary ventilation is going to be your diaphragm, right? What is pulmonary ventilation? Breathing, right? Pulmonary ventilation just means breathing. It's the fancy way of saying breathing. Pulmonary, you're talking about your lungs. So we're going to talk about the pulmonary artery and vein in chapter 15. Ventilation, ventilating your pulmonary area. No. Okay, so like pulmonary embolism is a blood clot in your lungs, your pulmonary. Pulmonary embolism is like a blood clot in your lungs, okay? So pulmonary, you're talking about your lungs. The rest of these are all just examples of accessory muscles. Now, pressure and airflow, you guys don't need to understand like the mechanics too much of this, okay? Atmospheric pressure drives respiration. What I mean by that, when you expand the rib cage, right? So you pull it open, you are decreasing that pressure, which is going to suck the air in, okay? When you squeeze your rib cage, you're pushing the air back out, right? It's the same thing as when you like squeeze a balloon, you shove the air out of that balloon, okay? Do not worry too much about knowing the ins and outs. The whole point of this, when you pull it open, pulls it in. When you push it out, pushes it out. Okay. There's a whole little analogy about airflow. If you guys want to read it, it's just about like opening a balloon and pushing a balloon out. So back to like what's in the packet. Okay. There are three main factors that are going to impact airflow. Okay. The first one is going to be the diameters of the bronchioles, pulmonary compliance, and alveolar surface tension. And we're going to go through each of these in depth. Okay. So, diameter of the bronchioles. Remember we said trachea splits into bronchi, which splits into bronchioles, which are then going to split into alveolar ducts, which lead to the alveoli, right? So diameter of the bronchioles, those tubes at the end there. They're going to change to control resistance, right? If something is a bigger hose as opposed to a little hose, water will flow faster in the bigger hose than it will in the smaller hose, right? Because that resistance is going to change. So diameter of bronchioles, that is going to be your first factor that affects airflow. Next, we have pulmonary compliance, okay? Pulmonary compliance is you are talking about the elasticity of lung tissue. Now, we talked about elasticity when we talked about muscles, right? Elasticity is the ability to contract back to the original shape. So pulmonary compliance, you need to be able to expand your lungs and you need them to shrink back down. You have diseases that can cause scarring like tuberculosis or black lung disease that are going to prevent the lungs from fully expanding. And as well as like contracting. So some things like emphysema makes the lung tissue like loose. So it doesn't like push the air back out all the way, which means it prevents more air from coming in because you have like a backup. Okay. So pulmonary compliance, that is another thing that affects airflow. Third thing, alveolar surface tension. So remember how I said the alveoli are super, super, super thin, right? They are only 1 cell thick, okay? You have on the inside of your alveoli, you have water, okay? And remember all the way back to chapter 2, right? There are these attractions between water molecules called hydrogen bonds. So water molecules really, really, really want to attach to one another, all right? They want to attach to one another stronger than the cells are able to hold up. So we have this stuff called surfactant that's going to break up that surface tension. All right. So that is going to allow those alveoli to stay inflated, to not collapse on themselves once the air has left. Now, surfactant is really important when we talk about premature infants, okay? Babies that are born before 28 weeks often lack surfactant. So what happens is those attractions between the water molecules cause the alveoli to collapse, okay? Sometimes you can administer artificial surfactant, but it doesn't always work. Just a fun fact about premature babies, because I always share this story. There was a guy back in like the 1920s, I think it was. So before like the 1920s, premature babies were pretty much just like given up on. They just said like, this baby's gonna die, and that's just the way life is, right? So this guy back in the 1920s was like, I think I can do something about this. So he started adopting all these premature babies, and he started something called the Infantorium, and started basically like a sideshow in Coney Island with these babies in incubators. And he would charge people admission to come in and see these babies. And with that money, he hired nurses to take care of these babies around the clock. And he was actually able to like save the lives of hundreds of babies. I think actually like almost 1,000 maybe. I could be wrong about that, but there was a lot of babies saved. And it really like challenged the way that they thought of like premature infant care. So they started doing like studies on it, because they were like, oh, I guess these babies can be like saved after all. So very cool. Used to be down in Coney Island. I was living in Coney Island, so just a cool fun fact. So next we have these things called measures of ventilation that is going to tell us how well the lungs are working. Okay. First thing we have tidal volume. Your tidal volume is just the normal amount of air moving in and out of your lungs. Okay. So it is just the normal amount of air you breathe in during one respiratory cycle. Inspiratory reserve volume, that is going to be the maximum amount of air that you can inhale. Okay, so that is when you take a deep breath in, that is how much air you can take in. Just to give you guys a like estimation, this is 591 milliliters. So a tidal volume, like a normal air cycle, is about 500 milliliters. Expiratory reserve volume is the maximum amount of air that you can breathe out. Now, no matter how hard you breathe out, okay, you will never be able to get rid of all the air in your lungs. Okay, so that leftover air in your lungs, that is going to be your residual volume. All right, so tidal volume during one regular cycle. Inspiratory reserve volume, when you suck in as much air as possible. Expiratory reserve volume, you breathe out as much air as possible. Residual volume is what's left over. Then we have these things called capacities. Capacities are going to be like sums of these. So your vital capacity is going to be the air that can move in your lungs. So it's going to be your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. Okay, so vital capacity, you're talking about the amount of air that can move in your lungs. Total lung capacity is the total amount of air that can be in your lungs. So that is going to be your vital capacity plus your residual volume. Okay, so I have both labeling for this as well as, excuse me, it written out in text. Okay, so if you prefer to see the text, it's here for you. Common respiratory terms, you're going to see this with PANOPEN, but if it's not in PANOPEN, don't worry about it, okay? Use PANOPEN to like base your like medical terminology questions on, okay? Just something good to know. PNEA, P-N-E-A, you're talking about breathing. So Brady means slow, PNEA, breathing, bradyapnea, slow breathing. Dyspnea, labored breathing, so on and so forth. So then you know half the list already. Transport of oxygen. So when oxygen comes into the lungs, it is going to bind to hemoglobin. 98.5% of oxygen is going to bind to hemoglobin. Only 1.5% of oxygen is just dissolved in blood plasma. Okay. So what does oxygen bind to when it comes in the bloodstream? Hemoglobin. Now, once it binds to hemoglobin, okay, the hemoglobin is going to carry it to the cells. And when it reaches the cells, there's a change in pH in the bloodstream. And that is going to cause the hemoglobin to be released. Okay. So just to give you an idea of what hemoglobin looks like, okay, hemoglobin has these iron molecules inside of it that oxygen is going to bind to. When they reach the tissues, that oxygen is going to get released. Now, when you measure O2 saturation, okay, O2 saturation is going to be the number of oxygen molecules that hemoglobin takes up. Okay, so although hemoglobin has the capacity to pick up 4 molecules of oxygen, right? So you have 4 spots that oxygen combine. It does not always pick up all 4. So when you measure O2 saturation, what you're measuring is the number of oxygen molecules that are inside of a hemoglobin thing. So that can tell you about lung function, it can tell you about circulation, okay? It can be indicating a couple of different problems. So usually you want your SpO2 to be about 98%, can be 97, can be 98, those are fine. 96 is also okay. PR, that's going to be your pulse rate. So you guys will take partial pressure of oxygen and pulse quite a bit with those like little finger thingies. Now, carbon dioxide. Carbon dioxide is going to be that waste product that our cells make, right? It is also going to get transported back to the lungs in one of 3 ways, one of which is going to be by binding to hemoglobin. Okay. Now, carbon dioxide is different than carbon monoxide. Okay. Carbon dioxide, di means 2. Mono means 1. So carbon dioxide, you have 2 oxygens. Carbon monoxide, you have 1 oxygen. Now, the reason why carbon monoxide is so dangerous, okay? Carbon monoxide also binds to hemoglobin. But when carbon monoxide binds to hemoglobin, hemoglobin likes being bound to it more than it does to oxygen. It has a higher affinity for it. So once carbon monoxide binds to that hemoglobin, hemoglobin can no longer transport oxygen. Okay, so once bound to carbon monoxide, hemoglobin cannot transport oxygen. So this is why carbon monoxide is so dangerous, because once you bind it to that hemoglobin cannot transport oxygen. You are essentially suffocating your cells. Now, as you get older, you're going to see a couple different...
What was the last part? You said once bound to carbon monoxide, hemoglobin can't
transport oxygen. So just get a little carbon monoxide detector. They're like $20. I don't know. My dad always told me to have one. He's a firefighter. So I listened to his advice. Just plug it in and forget about it unless it starts beeping and tells you to get out of the house.
All right, I get it. Thank you.
Yeah. So as you get older, a couple changes in your respiratory system, right? Decreased mobility of the chest wall, increased lung rigidity, decreased number of alveoli, weakened respiratory muscles, whole bunch of things, right? Basically, this all is going to lead to problems with clearing mucus and clearing bacteria. All right, so this is why older individuals are at a higher risk for developing pneumonia after a bacterial or a viral illness. Okay. Because they are not as able to clear all that stuff out. Now, oxygen therapy. Oxygen therapy is going to be administered when lungs or airways are compromised. Okay. The whole point of oxygen therapy is to make sure that there's enough oxygen to meet the body's needs. So what happens is the oxygen therapy is going to increase the amount of oxygen available for gas exchange. Right? So if you are not bringing enough oxygen into your body, one of the ways that you can counteract this is making more oxygen available. Right? So if you're still taking in 80%, but you're taking in 80% of 100 as opposed to 80% of 10, right? You're taking in more oxygen. So oxygen therapy just puts more oxygen in the body to give your body more opportunity to take it up. So what does oxygen therapy do? Ensures there is enough oxygen to meet the body's needs. Ooh. So oxygen therapy, you can give it through a face mask. You can give it through a nasal cannula. Okay. Depends on like what the needs of the patient are. So. Oh, I didn't even realize I moved my entire Coke can there. Okay, so just a quick little, I don't know, fun video. For respiratory system, let's do an MCQ. Ten more seconds. Yeah, so the primary way oxygen gets transported in the blood is going to be in the form of oxyhemoglobin. Oxy meaning there is oxygen. Hemoglobin is bound to hemoglobin. Okay. So, all right. So let's go ahead and do a 10-minute break. And I will see you guys in 10 minutes. So now we are going to go into chapter 19. Remember, chapter 19 is in that same packet that I handed out to you guys. Okay, so chapter 19, we are going to cover the urinary system. Okay, like 10 more seconds. So, a client with pancreatitis is admitted. Pancreatitis, what organ does it affect? The pancreas, right? And then what does itis mean?
Inflammation.
Inflammation. Okay. So if something is inflamed, is it big or is it small?
Bigger.
Bigger. Okay. So if something is bigger, it is probably going to be producing more of whatever is supposed to be producing. So knowing nothing else other than you have pancreatitis, that tells you that it's going to go up. Okay. So if you don't remember that pancreatitis or the pancreas makes amylase and lipase, doesn't matter. You know that it's increasing, right? Bile. Does anybody remember what organ's going to produce bile?
The liver.
The liver. Okay. So low bilirubin or bile, that would be indicative of some liver problems. Alkaline phosphatase we didn't talk about, but it's normal. And if you have pancreatitis, it shouldn't be normal, right? So next, talking about the urinary system, okay? Your urinary system is going to be composed of your kidneys, your ureters, your urinary bladder, and your urethra, okay? The whole point of the urinary system, okay, is to excrete metabolic wastes, drugs, hormones, salt, and water. So all things that can be dissolved in water. Where is my chapter 19 packet? There we go. Just want to make sure that I'm following along for you guys. Now, just to give you an idea of where on the body your kidneys are, they're going to be towards the back, okay? And they're going to be under your like 11th and 12th ribs. So they do have a little bit of protection, but not a ton.
Can you repeat what the system consists of one more time?
Yeah, I'll just go back right here. Kidneys, ureters, urinary bladder, and urethra. Okay. So first looking at your kidneys, okay? Your kidneys are going to be composed of two parts. The outer region is going to be your renal cortex, and that is going to be the site of urine production. Okay, so this is where urine is produced. Renal medulla is going to be the site of urine collection. Okay, so once the renal cortex has made the urine, it gets funneled down into the renal medulla. The renal medulla is going to be the inside of the kidney. Now it gets organized into these little triangles called pyramids, and then the urine kind of gets filtered down into this thing called the pelvis and goes down the ureter eventually. Okay, you guys will not need to know all the ins and outs of your kidney structure. Really want you guys to focus on knowing renal cortex is the site of urine production, and the renal medulla is the site of urine collection. Your book, again, has this very detailed diagram. For these last 3 chapters, your book goes into way more detail than you guys need to know. So now looking at renal circulation, okay? You are gonna have oxygenated blood coming into your kidney, and you are gonna have deoxygenated blood going back towards the heart, okay? We're gonna get more into your IVC and your aorta when we get to the heart, which is gonna be chapter 15, but just to give you an idea of how it relates to your urinary system. That's where we're going. Okay. So probably the most important terminology that you are going to learn, nephrons. Nephrons are the filtration units of the kidney. Now they're primarily going to lie in that outer region, so that cortex. So the reason I really like this diagram, you do not need to know juxtamedullary versus cortical, okay? The cortex, that outer region, right? So if you look at the structure of the nephrons, okay, you can see that the main part of them is going to be located in that cortex. They do dip down into your medulla, okay? But eventually what happens is they come back up into that cortex and they are going to go down this thing called your collecting duct, okay? And it is going to go down into your medulla. Okay. Does anybody remember what afferent means?
Arrive.
Arrived. What about efferent?
Exit.
Exit. Proximal.
Close
Close.
What?
to the midline.
Not to the midline.
Point of origin.
Point of origin. So where something starts. Okay. So proximal means closer to the point of origin. Distal means further from the point of origin. Okay. You're going to see these terms come up when you're seeing the different parts of the nephron. So it's just a good little refresher, because again, we're starting to review for the final, right? So what happens is blood flows through the nephrons. The nephrons are going to come in, or sorry. Basically, the whole point of this diagram is just to show that there are a lot of arteries and veins that surround each of these nephrons, okay? Because you are going to be secreting things into this glomerulus and then reabsorbing everything. Your nephron has 2 main subdivisions. You have your renal corpuscle, which is going to be where blood plasma is filtered. And then you have your renal tubule, which is going to be where urine is formed. Okay. Now your renal corpuscle specifically has 2 parts to it that we're going to talk about, but I'm going to give you a second to write this down.
Professor, how do you pronounce the second one? Renal, the one that starts with a T?
Tubule.
Tubulo?
Tubule.
Okay, thank you.
Jasmine?
What is the filtration unit of the kidney?
Nephron.
Can you please go sit down? I'm in school.
Jasmine, you're still unmuted.
Oh, I'm sorry.
No worries. Okay. So your renal corpuscle is going to be where blood plasma is filtered. And what I mean by that, okay? The way that urine formation works, okay, is like cleaning a fridge. So you take everything out of your fridge, you wipe down your fridge, you put the stuff back in that you want, and you throw away the moldy food. Okay? So the renal corpuscle is going to be the step where you're pulling everything out of your fridge. It has two parts to it. You have your glomerulus and your Bowman's capsule. Your glomerulus is literally translated to a ball of yarn. Comes from Latin for ball of yarn. Okay? So your glomerulus is this bundle of capillaries, all right? The afferent arteriole is going to bring blood into that glomerulus, and the efferent arteriole is going to take it away after it has filtered out everything. Your Bowman's capsule is going to surround that glomerulus, okay? So if you imagine like punching your fist into a balloon, that balloon is going to surround it. All right, so you have a double membrane, and then you have a space in between those two membranes. That is your Bowman's capsule. All right. So the renal corpuscle is going to be where that first step happens, where you are taking everything out of your fridge. Next, it is going to pass into your renal tubule. Your renal tubule has 4 parts to it. You do not need to know the parts. Bria?
I missed the part where it's the space for the walls of glomerular.
Oh, you don't need to, yeah, so the walls of the glomerular capillaries, we haven't gotten to that yet.
Oh, okay. Sorry.
No, you're good. Okay. So the renal tubule, you have 4 sections to it. Okay. Proximal convoluted tubule, nephron loop, distal convoluted tubule, collecting duct. The only reason I point them out, you'll see them mentioned in the videos that I have for describing how urine is formed. Basically, the whole point for them, different things get filtered at different sections or like reabsorbed at different sections. Okay. You're not going to need to know what gets reabsorbed where. They all end up collecting at the collecting duct, which is going to push things down to the renal medulla. Okay, let's do like 10 more seconds. Yeah, so the filtration units of the kidney are going to be the nephron. Okay. Renal corpuscle and glomerulus are all part of the nephron. The renal pelvis is just where all of the urine ends up going down to the ureter, but we don't cover that this time. So urine formation is going to involve 3 processes. You have glomerular filtration, tubular reabsorption, and tubular secretion. Okay. Glomerular filtration, that is going to be pulling everything out of the fridge. Tubular reabsorption, you're putting the things back in that you want to keep. Tubular secretion, throwing away the moldy food. Okay, so the way that glomerular filtration works, okay, the walls of your glomerular capillaries are going to be dotted with pores. Water and small solutes that are able to dissolve in that water are going to filter out. So that's going to be that fill in the blank. Okay, they filter out of the capsule. Now, things that are too big. So for example, blood cells and plasma proteins are too large to pass through the pores typically. So they are going to stay behind. Okay, so for that, blood cells do not filter in the Bowman's capsule normally. It is because they are too big. Now using just logic, okay? I'm skipping the slides. I forgot to take these out. I'm going to delete them, but basically the point of this one, the afferent arteriole is going to bring blood in, okay? And it is going to force the fluid out. So it's like if you're squeezing cheesecloth, right? It's going to force the fluid to pass out quicker, okay? And we'll talk about the system that regulates all of that in a little bit, okay? But your afferent arteriole is going to control, that's what the slide is saying. The afferent arteriole is going to control the rate at which like that fluid is flowing in. So how hard you are squeezing on that cheesecloth, okay? Proteinuria, protein, you're talking about proteins. Urea, you're talking about urine, okay? Proteinuria is just protein in the urine. Typically, you don't want to see protein in the urine, but if you have damage to that membrane, it can lead to protein in the urine. So proteinuria, protein in the urine, really easy. Okay. Now, a common cause of kidney damage and kidney failure is going to be uncontrolled hypertension. Okay. Systemic hypertension pushes the normally high glomerular pressure even higher. Basically, it puts damage on that glomerular membrane, which can cause damage. You don't need to know too much about that. Now, GFR, glomerular filtration rate, that's just talking about the rate at which you're producing urine, basically, okay, is going to be controlled by this hormonal system called renin-angiotensin-aldosterone system. You can just write RAS, R-A-A-S for short, okay? And the reason why we really need to tightly control this, if you are filtering too high, or you're flowing too quickly, okay? You're going too fast. Your body's going to lose excess water and nutrients. If it is too low, your body's going to have time to like reconsider the toxins that I got rid of, and it's going to take them back, okay? So if it's too slow, the tubules may reabsorb toxins. So you need to really tightly control this flow. The hormonal system that controls this is your renin-angiotensin-aldosterone system. And the way this works, okay? So your blood pressure is going to drop, all right? You have these cells called juxtaglomerular cells right outside your glomerulus. And you don't need to know in depth how this system works. It's just to give you an idea and also to briefly mention how ACE inhibitors work to put that into context, okay? So what happens is your blood pressure drops. Okay, these cells called juxtaglomerular cells coming into your nephron are going to sense that. And they're going to secrete something called renin. The renin is going to travel to the liver, okay? And the liver is going to start to produce something called angiotensin 1. Angiotensin 1 gets sent to the lungs, okay? And the lungs are going to convert angiotensin 1 into angiotensin 2 using something called angiotensin converting enzyme, which is shortened ACE. Angiotensin 2 then goes down to the adrenal glands, where it's going to stimulate aldosterone production. Aldosterone is going to increase water reabsorption. Now, ACE enzymes, or sorry, ACE inhibitors, okay? ACE inhibitors are blocking this step. So they get used for hypertension because when you block that step, right, you are blocking water reabsorption, which means you are peeing off more water, which is going to decrease blood volume, thereby decreasing blood pressure. So that's how ACE inhibitors work. Talking about diuretics. Diuretics are going to administer to increase urine volume. Okay. So they're useful in the treatment of hypertension and CHF. Okay. So congestive heart failure. There's a couple of different ways that they can affect your body, like tubular reabsorption, which blocks reabsorption of water, Okay. So some terminology, diuresis is just the passage of large amounts of urine. Antidiuretic is the prevention of large amounts of urine. Okay. Bria.
Antidiuretic, you said it means prevention of large amounts of urine. So what's the prevention part? Like how does that happen? Like how do they do that?
So a lot of the time it'll increase like tubular reabsorption of sodium. Because when you mess with how sodium gets reabsorbed, like how much of it, basically water wants to follow salt. So if you're changing the levels of salt, because you don't really want to affect how you move water in the body too much if you can, like directly, because that can impact other cells. So instead you can like focus on how your body is like reacting to sodium. So if you do the opposite of this by like increasing reabsorption of sodium, you can increase the water reabsorption, right? If you're increasing the amount of water that your body retains, it's going to decrease the amount of urine that you're making. Does that make sense?
It does.
Okay. So this video I like because it gives you guys a really good idea of how urine is made. Okay. Now, again, I don't expect you guys to know what the specific parts of the tubule are doing or anything like that. Okay. The whole point of this is I want you guys to have a little bit of background for when we talk about urinalysis so that you're understanding why you don't want to find certain things in your urine or why these findings could be abnormal, if that makes sense. Okay. So it's more to like give you guys background information, but I do like how he describes all the stuff. Plus he has a very enthusiastic voice. So So, like I said, mainly just to like give you guys background on how urine is forming. Now, like he said, water is going to be 95, or urine is 95% water and 5% dissolved solids. Okay. So for the question, what is the main component of urine? It is going to be water. Now, some things that you can find in urine that may indicate a disease process. So basically things you should not be finding in urine. Glucose, blood, free hemoglobin, albumin, ketones, bile pigment. You should not see any of these in urine. So in order to like examine urine, we have something called urinalysis. Okay. So an examination of the characteristics of urine. So basically you're looking at what urine is made of, or like what it looks like, what it smells like, how much it is, so on and so forth. Okay. So I'll give you guys another second for that. Ten more seconds and then I'll move on. Okay. So typically when you're looking at urine, it should be yellow. Okay. It can be transparent yellow to like dark yellow, depending on how hydrated the person is. Okay. It should be clear. You don't want to have cloudy urine. Cloudy urine can come from bacteria and indicate an infection. Odor, it should be a mild odor. All right. Now, if you've ever changed a diaper, right? At first that diaper doesn't smell, but if you leave that diaper out forever, or you just like haven't changed the baby in a while, right? It starts to smell because that bacteria starts to break things down and converts a urea into ammonia. Sweet fruity odor often occurs in diabetes. I don't remember if it was you guys that I told, but like back in the day, doctors used to drink urine to tell if somebody had blood sugar problems. So really archaic way of testing for diabetes, but it was done. Rotten odor may indicate a urinary tract infection. Next thing, specific gravity basically tells you how much solid stuff is in the urine. pH scale should have an average pH of about 6.0. A high pH indicates alkalosis, low pH, acidosis. So if ketones are in your urine, it's going to decrease that pH and cause ketoacidosis, like we talked about in chapter 22 with diabetes, right? Now, once urine leaves the kidneys, it is going to go down into the bladder via the ureters, okay? Now, like he said, it does not just like fall down into the bladder. The ureters have like peristalsis to push that urine down into the bladders. So for that true false, it is going to be false. Okay. Now, the whole point of the bladder is to store urine. Just like in the digestive system, right? The point of the stomach was to store food. Okay. So both of them have these structures called rugae. All right. Those are going to be those folds that allow that bladder and that stomach to expand as it fills up. Now, the bladder can hold about 500 ml of urine. So again, 16-ounce bottle, that is 591 ml, so a little bit less than that. Or it wants to hold about 500 ml. Okay. Now, you have these two things called your internal and external urinary sphincter, which we're going to talk about in a little bit. Okay. At 500 ml, that is when you start getting the urge to pee. 800 ml is like max capacity. Okay. So once we leave the bladder, we are going to go down through the urethra. Men are going to have a much longer urethra than females. Men have a urethra of about 20 centimeters. Okay. And just remember that male urethras are also part of their reproductive tract because they are carrying semen. Now, females, the female urethra is only about 3 centimeters long. Okay. The reason why this is clinically significant, it makes women much more susceptible to bladder infections in the cases of UTIs. Okay. So once your UTI has reached your bladder, it is a lot harder to treat. Brianna?
Yes. Did we go over what was the main purpose of the bladder? Did I miss that?
To store urine.
Okay. Thank you.
So men have a longer urethra. Why is this clinically significant? Because it makes women more susceptible to bladder infections in the case of UTIs. Okay. Because once bacteria gets down in the urethra, right, it's going to kind of like multiply and travel upwards. It has a lot less distance to cover in women than it does in men. Now, micturition. Micturition is just the fancy word for urination. Okay. It is voluntary to a certain extent. Just like in your anus, okay, you have your internal and external urinary sphincter. Your internal urinary sphincter is voluntary, okay? So what happens is 500 ml, your brains or your body starts telling you, hey, we need to go to the bathroom, right? If you ignore that impulse and your kidneys don't stop producing urine. They just keep going, you know? They don't care how much urine is already in there. They're just going to keep going, all right? At some point, like when you get to 800 ml, your body just says, hey, this guy isn't listening. Let's just go. Okay. So it takes over at some point and becomes involuntary. So it is both because it is voluntary to a certain extent, and then your brain takes over and it becomes involuntary. No. Something you guys are going to experience a lot. Foley catheters. Okay. Foley catheters are inserted into your urethra, and they go up to your bladder, and they are going to continuously drain urine. All right. You guys are going to come across catheters quite a bit. You want to recognize any blockage, kinking, so like somebody's sitting on it or something like that, that prevents proper bladder drainage. Okay. You also want to keep an eye to make sure that no like bowel movements get in there, none of that. Okay. Now, the important thing with catheters, you need to be monitoring urine output. Okay. This isn't just monitoring how much comes out. So this is going to give you an idea of how well the kidney is functioning. So normal urine output is going to be about 30 ml per hour. Low urine output is something called oliguria. So urea means urine, olig means low. It can be a sign of dehydration, blockage, or kidney dysfunction, right? So pretty straightforward. Dehydration, you don't have enough water, your body doesn't want to get rid of the water it does have. Blockage, something's going on that's preventing you from creating that urine. Kidney dysfunction, again, something's going on that's preventing that. High output, so poly means high, urea, urine, or multiple means a lot, okay? Is going to result from diuretics. We've already talked about diuretics, right? Those are going to produce high amounts of urine, or uncontrolled diabetes. You guys do not need to know the physiology behind it, so I'm not going to explain it because I'm worried that it'll confuse you. Now, as you get older, natural changes happen. One of the more important ones, you get a decreased number of those functioning nephrons, so the kidney's filtering units. Okay? You're also going to have reduced renal blood flow and therefore glomerular filtration rate. Slower excretion of waste of medications, decreased thirst and fluid intake. Okay? What this means is older adults are going to clear medications more slowly. That allows that drug to build up, something called drug toxicity. So decreased number of functioning nephrons, increased risk of drug toxicity. Now, this is a problem because a lot of drugs are eliminated by your kidneys. So if your kidneys are not working as well as they used to, you need to take this into consideration with medication dosage. So you can either give somebody a lower dose, okay, or space them further apart. What this does is it allows their bodies time to process, okay? So with lower doses, less medication, right? Spaced further apart, you have time for your body to absorb that or process that medication, okay? Now, healthcare providers are going to monitor these things called creatinine levels and glomerular filtration rate to determine kidney function before adjusting dosages. You guys should be watching out for signs of drug buildup, so on and so forth. Okay. This is all just like the urine formation stuff that we already talked about in the video. And again, you guys don't need to memorize the like subparts of the nephrons. So okay. So Brianna.
Sorry, that was an accident.
Oh, no worries. Okay. Ten more seconds. Yeah. So result indicative of a UTI, cloudy sediment with urine. Okay. Can indicate the presence of bacteria, white blood cells, pus. Normal urine output and clear urine don't indicate anything related to an infection. Loop tubing can increase your infection risk, but it is not a direct sign of infection. Okay. So cloudy urine with sediment. Okay. So that's where we will leave off for today. We're going to cover chapter 15 on Monday. Again, exam scores should be out Monday afternoon. If you have makeups, so I can't really send them till. All right. Have a good rest of your night, guys. I will see you then.
Thank you. You too. Good night.
Thank you. Good night.
Good night, guys.
Thank you. Good night.